Basic hygiene measures provide patients additional comfort before surgery. During major surgery, an anesthesiologist positions a patient's head to place an endotracheal tube into the airway. This involves manipulation of the hair and scalp. To avoid injury, ask the patient to remove hairpins or clips before leaving for surgery. Electrocautery is frequently used during surgery. Hairpins and clips can become an exit source for the electricity and cause burns. Remove hairpieces or wigs as well. Patients can braid long hair and wear disposable hats to contain hair before entering the OR. When using a pulse ox, have patients remove all makeup and at least one artificial fingernail to expose normal skin and hair color. Anything in or around the eye irritates or injures the eye during surgery. Have patients remove contact lenses, false eyelashes, and eye makeup. Give the patient's eyeglasses to the family immediately before the patient leaves for the OR and document all the valuables per agent policy in the electronic health record. It is easy for any type of prosthetic device to become lost or damaged during surgery. Have patients remove all prosthetics for safekeeping just before leaving for the OR. Place prosthetics in a secured area or give them to family members and document per agency policy. If a patient has valuables, give them to the family members to secure. Prepare a list with a description of items, place a copy in the patient's medical record, and give a copy to a designated family member. Patients are often reluctant to remove wedding rings or religious medals. A wedding band can be taped in place, but this is not the preferred practice. Many hospitals allow patients to pin religious medals to their gowns, although the risk of loss can increase. Remove other metal items such as piercings to reduce the risk of burns. Some patients receive an enema or cathartic the morning of surgery. If so, give at least 1 hour before a patient leaves for the OR to allow them ample time to defecate without rushing. The surgeon may order insertion of an indwelling catheter if the surgery is to be long or the incision is in the lower abdomen. Monitor preoperative vital signs before surgery. The anesthesia provider uses these values as a baseline for intraoperative vital signs. If preoperative vital signs are abnormal, surgery may need to be postponed. Notify the surgeon of any abnormalities before sending the patient to surgery. Hospitals have made the prevention of deep vein thrombosis or blood clots a priority quality measure. When correctly sized and applied, anti-embolism devices such as stockings can reduce the risk of DVTs. The anesthesia provider or surgeon may order pre-anesthetic drugs to reduce patient anxiety. The amount of general anesthesia required, respiratory tract secretions, and the risk of nausea and vomiting and possible aspiration. Complete all nursing care measures before administering these medications. Preoperative drugs can cause dry mouth, drowsiness, and dizziness. If drowsiness or dizziness occurs, keep side rails up in the up position, the bed in the lowest position, and the call light within easy reach. Be sure the patient has a signed surgical consent before administering any medications that's going to alter their level of consciousness, like pain medications or sedatives. Before the patient goes to the OR, an accurate medical record is essential to ensure safe and appropriate patient care. Check the contents of the medical record for accuracy and completeness. The transfer of information about the patient from one healthcare provider to another requires an effective handoff. The Association of Perioperative Nurses recommend timeouts for safe surgery briefings during a pre- to intraoperative handoff. This ensures that the right patient receives the right surgery at the right surgical site. Implement the universal protocol whenever an invasive surgical procedure is to be performed, no matter what location. The three principles of the protocol are a preoperative verification that ensures that all relevant documents and results of lab tests and diagnostic studies are available before the start of the procedure, and that the type of surgery scheduled is consistent with the patient's expectations. 2. Mark the operative site with an indelible ink to mark left and right distinction, multiple structures, and the level of the spine. 3. A timeout just before starting the procedure for final verification of the correct patient, procedure, site, and any implants. The marking and timeout most commonly occur in the holding area, just before the patient enters the OR. The individual performing surgery and who is accountable for it must personally mark the site, and the patient must be involved if possible. The nurse caring for the patient in the preoperative area evaluates initial patient outcomes. Compare the patient's current status with expected outcomes to determine whether new or revised interventions or nursing diagnoses need to be implemented intraoperatively. During evaluation, include a discussion of any misunderstandings so patient concerns can be clarified. When patients have expectations about pain control, this is a good time to reinforce how it will be managed after surgery. Evaluate the patient's response to interventions designed for preoperative nursing diagnoses, such as deficient knowledge or anxiety. Observe the patient's behaviors and discuss concerns to see if anxiety has been resolved or relieved. Be thorough in your evaluation to determine if further instruction or emotional support is needed after surgery. Interventions continue during and after surgery, thus the evaluation of many goals and outcomes does not occur until after surgery. Personnel in the OR notify the nursing unit or ambulatory surgery area when it is time for surgery. In many facilities, a nursing orderly or transporter brings a stretcher for transporting the patient. The transporter checks the patient's identification bracelet for 2 identifiers against the patient's medical record to ensure the correct person is going to surgery. Because some patients receive preoperative sedatives, the nurse and the transporter help the patient transfer from bed to stretcher to prevent falls. The ambulatory surgery patient ambulates to the OR if able and not medicated. Provide the family an opportunity to visit before the patient is transported to the OR. Direct the patient to the appropriate waiting area. If a patient has been hospitalized before surgery and will be returning to the same nursing unit, prepare the bed and room for the patient's return. In most cases, a patient enters a pre-anesthesia care unit or pre-surgical care unit, sometimes called the holding area outside the OR, where preoperative medications are completed. Nurses in the PCU are members of the OR staff and wear surgical scrub hats, footwear in accordance with infection control policies. In some ambulatory surgical settings, a perioperative primary nurse admits the patient, circulates for the operative procedure, and manages the patient's recovery and discharge. If an IV catheter is not already present, a nurse or anesthesia provider inserts one into a vein to establish a route for fluid replacement, IV drugs, or blood products. The nurse also administers preoperative medications and or begins conscious sedation at this time. The nurse monitors vital signs, including pulse ox. The anesthesia provider usually performs a patient assessment at this time. Because of the preoperative medications, explain to the patient that he or she will begin to feel drowsy. The temperature in the PCU and adjacent OR suites is usually cool, so offer the patient an extra blanket. The patient will stay in the PCU only briefly. There are 2 traditional nursing roles in the OR, the circulating nurse, and the scrub nurse. The circulating nurse will remain unscrubbed and uses the nursing process in management of patient care activities in the OR. The circulating nurse also manages patient positioning, antimicrobial skin prep, medications, implants, placement and function of intermittent pneumatic compression devices, specimens, warming devices, and surgical count of instruments and dressings. The scrub nurse is either an RN or surgical technologist who is also a certified CST. The scrub nurse must have a thorough knowledge of each step of the surgical procedure and the ability to anticipate each and every instrument and supply needed by the surgeons. A circulating nurse and scrub nurse partner together to ensure patient safety by minimizing risk of error. The team also works together to ensure cost-effective use of supplies. A new role in the OR includes the registered nurse first assist. This is an expanded role that requires formal academic education. The RNFA collaborates with the surgeon by handling and cutting tissue, using instruments and medical devices, providing exposure of the surgical area and hemostasis, and suturing. Once a patient enters the OR, the circulating nurse thoroughly assesses the patient and critically analyzes to make patient-centered clinical decisions required for safe nursing care. The assessment usually focuses on the patient's immediate clinical status, skin integrity, and joint function, as the nurse reviews the preoperative care plan to establish or revise the intraoperative care plan as indicated. Review preoperative nursing diagnoses and modify them to individualize the care plan in the OR. Patient-centered goals and outcomes of preoperative nursing diagnoses extend into the intraoperative phase. For example, a goal for the nursing diagnosis of risk for thermal injury is skin will remain free of burn injury through surgical procedure. An expected outcome for this goal is patient will be free of burns from the grounding pad at the end of surgery. The circulating nurse uses judgment to provide a safe operative experience for the patient, ensuring an antiseptic environment, conducting instrument and sponge counts according to policy, managing tissue and specimens correctly, and assuring proper use of equipment and instruments are top priority. If an unsafe practice begins to occur, such as a break in sterility, missing sponge in the wound, the circulating nurse is integral to ensure the safety of the patient and operative personnel. For optimal patient safety, the preoperative healthcare team communicates assessment findings and patient problems via a formal handoff with the surgical team to ensure a smooth transition in care. For example, alerting the operative team of a latex allergy or risk factors for complications during surgery requires collaboration and timely communication among all team members. A primary focus of intraoperative care is to prevent injury and complications related to anesthesia, surgery, positioning, and equipment use. When the patient enters the OR, the patient is usually still awake and notices healthcare providers in their surgical attire and masks. You transfer a patient to the OR bed by being sure the stretcher and bed are locked in place. Explain to the patient all the activities that are being completed. After safely securing the patient in the OR table with safety straps, you will apply monitoring devices such as a continuous ECG, a pulse ox, a blood pressure cuff. For ECG, place electrodes on the chest and extremities to record a correct electrical activity of the heart accurately. The anesthesiologist will use the cuff to monitor the patient's blood pressure. An electronic monitor in the OR will display the patient's heart rate, vital signs, and pulse ox on a continuous basis. Capnography is also frequently used to measure the patient's ongoing end-tidal CO2 values. Apply an electric cautery grounding pad to the skin so cautery instruments can be used safely. If not applied preoperatively, now is the time to apply anti-embolism devices. To measure the patient's body temperature continuously, you might assist in insertion of a temperature probe via the bladder, esophagus, or rectum. The unplanned occurrence of perioperative hypothermia is now minimized with the use of active intraoperative warming. Prevention of hypothermia helps to reduce complications such as shivering, cardiac arrest, blood loss, surgical infections, pressure ulcers, and mortality. Evidence suggests that pre-warming for a minute of 30 minutes may reduce occurrence of hypothermia. The nurse in the OR applies warm cotton blankets, forced air warmers, or circulating water mattresses to patients. Forced air warmers tend to be the most effective when used preoperatively or intraoperatively. As the incidence and prevalence of latex sensitivity and allergies increase, the need for recognition of potential sources of latex is extremely critical. All medical supplies contain a label notifying the consumer of the latex content. A latex-free cart needs to be available at all times in the OR to create a latex-safe environment. It is important to know that patients may develop anaphylaxis 30 to 60 minutes after being exposed. The nature and extent of a patient's surgery and current physical status influences the type of anesthesia administered during surgery. Know the complications to anticipate postoperatively for each type. Under general anesthesia, a patient loses all sensation, consciousness, and reflexes, including gag and blink reflexes. There is muscle relaxation, and the patient experiences amnesia. Amnesia acts as a protective measure from the unpleasant events of the procedure. An anesthesia provider gives general anesthetics by IV infusion and inhalation routes through the 3 phases of anesthesia: induction, maintenance, and emergence. During emergence, anesthetics are decreased and the patient begins to awaken. Because of the short half-life of today's medications, emergent often occurs in the OR. The duration of anesthesia depends on the length of surgery. Regional anesthesia results in loss of sensation in an area of the body by anesthetizing sensory pathways. This type of anesthesia is accomplished by injecting a local anesthetic along the pathway of a nerve from the spinal cord. A patient requires careful monitoring during and immediately after regional anesthesia for return of sensation and a movement distal to the point of anesthetic injection. Serious complications such as respiratory paralysis occur if the level of anesthesia rises, moving upward in the spinal cord. Local anesthesia involves loss of sensation at the desired site by inhibiting peripheral nerve conduction. It is commonly used in ambulatory surgery. A local can also be used in addition to general or regional anesthesia. The anesthetic agent inhibits nerve conduction along the drug diffuses into the circulation. It is injected locally or applied topically. The patient experiences a loss in pain and touch sensation in motor and autonomic activities. It is necessary to continually monitor patients during a local procedure. IV sedation or conscious sedation is routinely used for short-term surgical, diagnostic, and therapeutic procedures that do not require complete anesthesia, but rather a depressed level of consciousness. The preferred sedative for conscious sedation is short-acting IV sedatives such as Versed. Prevention of positioning injuries requires anticipation of the position and surgical approach to be used during a surgical procedure, the positioning equipment to be used, and whether a patient has conditions creating a risk for injury. Although it may be necessary to place a patient in an unusual position, try to maintain correct alignment and protect skin from pressure, abrasion, and other injuries. Special mattresses, use of foam padding, and attachments to the OR table provide protection to extremities and bony prominences. Positioning should not impede normal movement of the diaphragm or interfere with circulation or body parts. If restraints are necessary, pad the skin to prevent trauma. Throughout the surgical procedure, the circulating nurse keeps an accurate record of patient care activities and procedures performed by OR personnel. A standardized documentation format assists practitioners in ensuring continuity of information from the OR to the PACU, or recovery area. The ORN recommends the use of verbal and standardized forms to transfer patient information between care providers. The circulating nurse conducts an ongoing evaluation to ensure that interventions such as patient position are implemented correctly during the intraoperative phase of surgery. While a patient is undergoing surgery, it is important to keep the family informed. Families expect an estimate of when surgery begins and the length of the time it will last. When you give an update to a family member, ask if she has further questions or concerns. Evaluate a patient's ongoing clinical status during surgery. The anesthesia provider will continuously monitor vital signs. The circulating nurse will monitor and record intake and output, specimens obtained, medications and irrigations, types of dressing packings, and other treatments. Measure the patient's body temperature during and at the completion of surgery with the goal of keeping the patient normothermic. Inspect the skin under the grounding pad and at areas where positioning exerts pressure. The type of anesthesia, nature of surgery, and the patient's previous condition determine the phases of recovery that the patient undergoes and the length of time spent in convalescence in the acute care unit. For a patient following ambulatory surgery, the immediate recovery period normally lasts 1 to 2 hours in phase 2 recovery, and convalescence occurs at home. However, phase 1 recovery may be necessary depending on the patient's condition and anesthesia. For a hospitalized patient, the immediate postoperative recovery period, phase 1, often lasts a few hours in the PACU, and phase 2 recovery occurs in a surgical unit. Convalescence then takes 1 or more days on the surgical unit. When a patient is admitted to phase 1 recovery, personnel notify the nurses on the acute care nursing unit of the patient's arrival. This allows the nursing staff to inform family members. When the patient enters the PACU, the nurses and members of the surgical team discuss the patient's status. A standardized approach or tool for handoff communication assists in providing accurate information about a patient's care, treatment and services, current condition, and any recent or anticipated changes. After receiving handoff from the OR, the PACU nurse conducts a complete systems assessment during the first few minutes of PACU care. Evaluate the patient's status and evaluate readiness for discharge from the PACU on the basis of vital sign stability compared with the preoperative data. Patients with more extensive surgery requiring anesthesia of longer duration usually recover more slowly. It is common for hospitals and ambulatory care centers to use objective scoring systems to identify when patients are ready for discharge. Standard tools include the Modified Aldrete score or the Modified Post-Anesthesia Recovery score and the DASAM discharge assessment tool. When the patient is discharged from the PACU, another handoff communication occurs at the patient's bedside between the PACU nurse and the nurse on the acute nursing unit or the ICU. The nurses verify the patient's identification using 2 identifiers and the type of surgery performed. The PACU staff transport the patient on a stretcher to the nursing unit. The PACU nurse shows the receiving nurse the recovery room record, and reviews the patient's condition and course of care. The PACU nurse also reviews the surgeon's orders that require attention. Before the PACU nurse leaves the acute care area, the staff nurse assuming care for the patient takes a complete set of vital signs and compares with the PACU findings. Minor vital sign variations normally occur after transporting the patient. The thoroughness and extent of postoperative recovery depends on the ambulatory patient's condition, type of surgery, and anesthesia. In some cases, the patient goes through both Phase 1 and Phase 2 recovery, assessing care for patients in need of close monitoring in the same fashion as inpatients in Phase 1. After patients stabilize and no longer require close monitoring, transfer them to Phase 2 recovery. When a new anesthetic agent and minimally invasive surgical techniques, fast-tracking surgery is becoming more common with patients experience a more rapid awakening in the OR, quicker recovery, and reduced morbidity. Many ambulatory surgery patients are able to bypass Phase 1. Phase 2 recovery is performed in a room equipped with medical recliner chairs, side tables, and footrest. Kitchen facilities for preparing light snacks and beverages are usually located in the area, along with bathrooms. The Phase 2 environments promote the patient's and family's comfort and well-being until discharge. Monitor patients, but not at the same time intensity as during Phase 1. In Phase 2 recovery, initiate postoperative teaching with patients and family members. Patients are discharged to home following the ambulatory surgery after they meet certain criteria. When you are using a tool for assessing a patient's recovery score, such as the PARS, the patient must achieve a certain score before being discharged. Review written postoperative instructions and prescriptions with the patient and family before releasing the patient and ensure that they verbalize understanding of these instructions. Always discharge the patient to a responsible adult. Inpatients remain in the PACU until their condition stabilizes. Then they return to the postoperative nursing unit. Nursing care in both settings focuses on returning the patient to a relatively functional level of wellness as soon as possible. The speed of convalescence depends on the type or extent of surgery, risk factors, patient management, and post-op complications. Once a surgical patient is transferred to an acute care nursing unit, ongoing postoperative care is essential to support recovery. Apply the nursing process and use a critical thinking approach in your care of patients. When the patient arrives on the acute care unit, monitor vital signs according to institution policy. Generally, the patient is monitored every 15 minutes twice, every 30 minutes twice, hourly for 2 hours, and then every 4 hours or per orders. As the patient's condition stabilizes, but the patient usually is monitored once a shift until discharge. Thoroughly document the initial nursing assessment, including vital signs, level of consciousness, airway status, condition of dressings and drains, pulse distal to the site of surgery, comfort level, IV fluid status, and urinary output measurements, and document your findings. When a patient initially returns to the acute care nursing unit, the family and patient have expectations of the patient receiving prompt and attentive care. There is also the expectation that a nurse will explain the patient's immediate status and the plan of care for the next few hours. The first priority in the care of a post-anesthesia patient is to establish a patent or open airway. Careful assessment of heart rate and rhythm, along with blood pressure, reveals the patient's cardiovascular status. Compare preoperative vital signs with postoperative values. Also assess circulatory perfusion. A common early circulatory problem is bleeding or hemorrhage. Blood loss may occur externally through a drain or incision or internally. Either type of hemorrhage results in a fall in blood pressure, elevated heart and respiratory rate, thready pulse, cool, clammy, pale skin, and restlessness. Notify the surgeon if these changes occur. A patient's anesthetically depressed level of body function results in a lowering of metabolism and a fall in body temperature. Older adults and pediatric patients are at higher risk for developing problems associated with postoperative hypothermia. In rarer instances, a genetic disorder known as malignant hyperthermia, a life-threatening complication of anesthesia, develops. Malignant hyperthermia causes hypercarbia, an elevation in CO2, tachypnea, tachycardia, premature ventricular contractions, which are irregular premature electrical beats, unstable blood pressure, cyanosis, skin mottling, and muscular rigidity. Despite the name, an elevated temperature occurs late. The increased carbon dioxide is one of the first signs. Without prompt detection and treatment, it is potentially fatal. Because an elevated temperature may be the first indication of an infection, assess the patient for potential source of infection, including the IV site if present, the surgical incision, and the respiratory and urinary tracts. Notify the healthcare provider because further evaluation is often necessary. Because of the surgical patient's risk for fluid and electrolyte abnormalities, assess the hydration status and monitor for signs of electrical alterations. Accurate recordings of I&O assess renal and circulatory function. In the PACU, the patient is often drowsy. And anesthetic agents begin to metabolize, the patient's reflexes return, muscle strength is regained, and a normal level of orientation occurs or returns. Continue monitoring neurostatus on the nursing unit. Ensure that the patient is oriented to self and the hospital and responds to appropriate questions. Assess pupil and gag reflexes, hand grasp, and movement of extremities. Patients with regional anesthesia begin to experience a return in motor function before tactile sensation returns. Check the patient's sensation to touch. Patients remain in the PACU until sensation and voluntary movement of the lower extremities are reestablished. During recovery and acute postoperative care, assess the condition of the skin, noting pressure areas, rashes, petechiae, abrasions, or burns. After surgery, a patient may only have butterfly tape, skin staples, or even glue to close small wounds. Look at the incision carefully and notice any drainage or swelling. Most surgical wounds that are larger have dressings that protect the wound site and collect drainage. Observe the amount, color, odor, and consistency of drainage on dressings. Nurses should monitor patient blood glucose levels routinely based on surgeon order or hospital policy. Depending on the surgery, some patients do not regain voluntary control over urinary function for 6 to 8 hours after anesthesia. Normally, patients who undergo abdominal or pelvic surgery have decreased peristalsis for at least 24 hours or longer. Paralytic ileus, which causes abdominal distension, is always possible after surgery. Auscultate bowel sounds in all 4 quadrants, noting faint or absent bowel sounds. Inspect the abdomen for distension that may be caused by accumulation of gas. Ask whether a patient is passing flatus, an important sign indicating return of normal bowel function. As patients awaken from general anesthesia, then sensation of pain becomes prominent. They perceive pain before re-engaging full consciousness. Ongoing assessment of the patient's discomfort and evaluation of pain relief therapies are essential throughout the postoperative course. Pain scales are effective for assessing postoperative pain, evaluating the response to analgesics, and objectively documenting pain severity. Using preoperative pain assessments as a baseline, evaluate the effectiveness of interventions throughout the patient's recovery. Determine the status of preoperative nursing diagnoses by clustering new postoperative assessment data. Then either revise or resolve preoperative diagnoses and identify new diagnoses after surgeries. It is common to identify new nursing diagnoses after surgery because of the risks or problems associated with surgery. Also consider the assessed needs of a patient's family when you identify nursing diagnoses. In the formulation of nursing diagnoses, be accurate in identifying a related factor when appropriate. During the convalescent phase, use current physical assessment data and analysis of the preoperative nursing history to plan the patient's care. The surgeon's postoperative orders and surgical team's report of the patient's operative condition also provide valuable data. Review nursing diagnoses when establishing goals, expected outcomes, and interventions for the individual patient. Measure outcomes provide specific guidelines for determining a patient's progress towards recovery from surgery. At times, goals and outcomes must extend from the convalescence period into the home setting. Also consider all goals of care established during the preoperative surgical phase that are still relevant. During the convalescent phase of recovery from general anesthesia, priorities for the first 24 hours continue to include maintenance of respiratory, circulatory, and neurological status, wound management, and pain control. In addition, most surgeons are aggressive in increasing the patient's activity as soon as possible. As the patient progresses, focus priorities on advancement of patient activity to return the patient to preoperative functioning or better. The patient generally has multiple nursing diagnoses. During recovery, collaborate on the plan of care with respiratory therapy, physical therapy, occupational therapy, dietary, social work, home care, and others. Include family members as much as possible, especially if they will be assuming care responsibilities in the home. The goal of an interdisciplinary approach to care is to help the patient return to the best possible level of functioning with a smooth transition to home, rehabilitation, or long-term care. Acute care settings often have a nurse or social worker in a case manager role to coordinate interdisciplinary care so the most appropriate resources are available to patients. A patient's only source of fluid intake immediately after surgery is IV. You typically will remove an IV catheter once a patient awakens after ambulatory surgery and is able to tolerate water without GI upset. A more seriously ill patient requires an IV to receive fluids and achieve hydration and electrolyte balance. When acute care patients no longer need a continuous IV infusion, the IV line may be locked to preserve the site for antibiotics or other use. Studies show that patients who chew gum after surgery experience a faster return of valve function and pass flatus significantly sooner than those who don't chew gum. A patient likely begins taking ice chips or sips of fluid when arriving on an acute surgical care unit. If fluids are tolerated, the diet progresses with clear liquids next. Interventions preventing GI complications promote return of normal elimination and faster return of normal nutritional intake. Advance a patient's dietary intake gradually. Promote ambulation and exercise. Physical activity stimulates a return of peristalsis. Patients without a catheter need to void within 8 to 12 hours after surgery. If the patient has an indwelling urinary catheter, the goal is to remove it as soon as possible because of the high risk for the development of a healthcare-associated bladder or urinary tract infection. Help patients assume their normal position to void, assess for bladder distension, and monitor intake and output. Strain on sutures from coughing, vomiting, distension, and movement on body parts can disrupt wound layers. Protect a wound and promote healing. A critical time for wound healing is 24 to 72 hours after surgery, after which a seal is established. If a clean surgical wound becomes infected, it usually occurs in 4 to 5 days after surgery. Monitor patients on an ongoing basis for fever, tenderness at a wound site, and presence of local drainage on dressings. Yellow, green, or brown and odorous. A clean surgical wound usually does not regain strength against normal stress for 15 to 20 days after surgery. Surgical dressings, if in place, remain in place the first 24 hours after surgery to reduce the risk of infection. During this time, add an extra layer of gauze on top of the original if drainage develops. After that, use a septic technique during dressing changes and wound care. Time any dressing change to begin 5 to 30 minutes after giving the patient pain medication. The appearance of wounds, bulky dressings, and extruding drains and tubes threatens a patient's self-concept. The fear of not being able to return to a functional family role causes some patients to avoid participating in the plan of care. Providing privacy during dressing changes or inspection of the wound. Maintain the patient's hygiene. Prevent drainage devices from overflowing. Maintaining a pleasant environment. Offer opportunities for the patient to discuss feelings about appearance. Provide the family with opportunities to discuss ways to promote the patient's self-concept. In the postoperative period, the nurse, patient, and family work to prepare the patient for discharge. Patients often have to continue wound care, follow activity or diet restrictions, continue medication therapy, and observe for signs and symptoms of complications or returning home. Education regarding these activities is specific to the type of surgery and is an ongoing process through hospitalization. It is important that nurses provide specific, culturally appropriate, and accurate verbal and written discharge instructions to enhance the ability of patients to care for themselves at home. With ambulatory surgical patients, focused education within the limited time frame is essential. Including the family or support system provides a resource for the patient once home. With both ambulatory and hospitalized surgical patients, provide a wide variety of written educational materials. For example, offer materials with more pictures and illustrations for patients who do not speak English or have limited ability reading. Ensure that all materials are sensitive to various cultures and religions. Patients receive a copy of signed discharge instructions and one remains on the chart. Surgical recovery is slowed if patients are deconditioned and frail. Recent research shows that the importance of keeping frail older adults active after surgery. A person is considered frail if they have 3 or more of the following: unintentional weight loss, low activity, slow motor performance, weakness, and fatigue. Aerobic exercise and physical resistance training have promised in improving patients' gait speed and ability to perform activities of daily living. Nurses must find strategies to help patients remain adherent to recommended exercise programs and realize the importance of involving family caregivers if patients have dementia or mental alterations. Some patients need home care assistance in the postoperative period after discharge. For example, nurses make referrals to home care for skilled nursing requirements when patients need wound care, ongoing IV therapy, or drain management. In addition, patients who are more physically dependent may require assistance from nursing assistance personnel to provide bathing and hygiene needs. The case coordinator or social worker at the hospital helps with discharge coordination. Other patients, especially older adults, may require discharge to a rehab or skilled nursing facility after their hospital recovery. During their convalescence, patients work to gain mobility and recovery of their independent living skills. In addition, nurses provide wound care and other specialized services. A case coordinator or social worker works with the patient family and nurse to coordinate transfer to the skilled facility. Addressing the ongoing concerns of patients and family members is an important part of evaluation after surgery. Purposeful hourly rounding meets patient needs and increases patient satisfaction. Nursing staff ask patients about their pain. If they need to go to the restroom, the patients are positioned for comfort, and an environment check is done of the periphery to ensure patients' possessions are in reach, such as the phone and call line. This is the opportunity to ask specific questions that address patient expectations and perceptions. It is important to resolve any concerns or issues that the patient and family have before discharge. Evaluate the effectiveness of your care on the basis of the patient-centered expected outcomes established after surgery for each diagnosis. Consult with the patient and family to gather evaluation data, and remember that evaluation is ongoing. If a patient fails to progress as expected, revise the patient's plan of care based on evaluation findings and the patient's needs. Make sure to evaluate for pain relief using a pain scale. Determine the efficiency of both pharmacologic and non-pharmacological measures. Use appropriate evaluative measures. Inspect the condition of the wound. Monitor usage of the IS. Measure the distance or number of times that the patient is able to ambulate, and monitor the amount of food and fluid intake. Part of your evaluation is determining the extent to which the patient and family learn self-care measures. Using the teach-back method of patient education ensures that the patient understands the information presented and the skills taught. Information is presented to the patient in a manner that the patients understand, and patient understanding is verified when the patient restates the information in the patient's own words. If the patient must perform any skill at home, such as dressing change or exercise, evaluate through return demonstration. Ensuring patient safety is an essential role of the professional nurse. To ensure patient safety, communicate clearly with members of the healthcare team, assess and incorporate the patient's priorities of care and preferences, and use evidence-based practice when making decisions about your patient's care. When performing the skills in this chapter, remember the following points to ensure individualized, patient-centered care. Coughing and deep breathing may be contraindicated after brain, spinal, head, neck, or eye surgery. Bariatric patients may not have improved lung function and vital capacity in the reserve, and they might do better in the reverse Trendelenburg or side-lying position. And report any signs of venous thromboembolism or DVTs, such as pain, tenderness, redness, warmth, or swelling in the upper or lower extremities, to the medical team immediately.